Good evening, my fellow humans. I had a comment and a question about cost containment. One of the things somewhat buried in the 2,000 pages of healthcare reform was an upgrade of the Center for Minority Health and Healthcare Disparities, which is a unit of the National Institutes of Health. That center was upgraded to an institute, which gave it more power and more influence. There's data that suggests or shows that healthcare disparities are an excess of cost of about 30.7% in the overall healthcare expenditures. I'd be interested in the comments that the panelists may have about the relevance of healthcare disparities and the cost containment benefit, and the importance, perhaps, of emphasizing this a good deal more, not only to save money, but because it's the right thing to pay attention to. Women, as you know, experience healthcare disparities, not just minority women, and that includes, obviously, our grandmothers, our mothers, our wives, our daughters, and granddaughters. And I believe this requires and deserves a great deal more emphasis, and it also relates to overall quality of care.
Any comments?
Well, I obviously totally agree with that. It's increasingly become obvious that the fact that we've allowed, and it's difficult to completely understand why it's happened. Some things are pretty obvious, that this disparities that exist in many parts of the country, if not most, in terms of the access to care, the knowledge, is obviously has a negative impact on the individuals, but also has a negative impact on the quality of care in America and on the costs. So the idea that we're willing to spend money, it's part of that 2,000 pages. And there's a lot of good things in this bill that we don't even talk about. And one of them is the idea that we're going to upgrade this program at the National Institutes of Health to a full institute and fund it at an adequate level not to begin, because we've already begun, to really understand what is causing these disparities and what we can do to change it. Because you're absolutely right. It's not fair. It's not morally right, but it's also not economically right. So the more we can do to understand it and to change it, the more we're better off.
Any other? Yes.
Professor Altman, do you think that going forward, similar hospitals will continue to be reimbursed at different rates for the same procedures?
All right, so the question is from my good friend, the chairman. Will hospitals, are you speaking particularly in Massachusetts or in general? We have if you look around this country, as I do, we have a hodgepodge of payment structures. My strong view is the answer is yes, we should pay hospitals differently, provided it's based on the quality and the efficacy of the care they produce. Instead, what we have is a lot of hospitals that pay differentially based on pure, unmitigated market power. And the closer we could get to moving reimbursement to the way those of you in business pay for things, we don't mind paying more for a more expensive car if we think we're getting value for that. So I don't have any problem in paying a hospital more for a higher quality output, for better care, higher quality, better facilities, and so on. What I object to is just either paying for without regards to value or paying on the basis of market power. So one of the things I've been working very hard to do, and it's going to take time, is to change the way we pay for hospital care and for physician care and move it along value. So again, I think the answer is yes, I think we should pay more differentially, but it should be based on a different set of standards than we now use.
Anyone else out there with your hands up? Yes.
There hasn't been a lot of discussion recently about malpractice reform, and I'm wondering, obviously lack of reform drives up quality of care and also drives up cost due to the increase in defensive medicine practice. And how do you see that maybe factoring into future iterations of the bill or into future practices in
For those of you who haven't heard, this issue about malpractice reform, I don't know if you want to answer it, but my sense is that, well, several things. First of all, there's no question that the idea that a physician stands the possibility, or a hospital, of being sued for services tends to push them to do things that maybe isn't really in the best interest of the patient, just as a defense of medicine. But this is America. Understand something. The #1 Olympic event in America is the ability to sue, And the fact that every third American, for those of, how many lawyers do we have in this room? How many? I bet you we have 10 times more lawyers than we have doctors. So I don't say this lightly. America's whole jurisprudence is based on the individual's right to sue. We are never, ever going to get away from malpractice. I don't care what it is. Now, with that said, we need to change the current system. It is destructive. It is destructive of patients, it's destructive of doctors, and it's destructive of hospitals. But one last thing I would say, we will not save nearly the amount of money you think so. Every study we have done, and economists have been looking at this for 10 years, turns out over time, defensive medicine has gotten built into the practice of medicine. And if all of a sudden tomorrow we were to end malpractice, it would take probably 20 years. Should we change it? Absolutely. Will we change it? I think so. Senator Kerry, I've been working with him. He had in his proposal, when he was running for president, a malpractice reform. He pushed it a little. It's going to take time. It's sort of like the religious issue. It's a different version of religion. It's just pushed on a different front. I don't know whether you've seen it.
I would say on that it does not have to be a national solution. It's the state malpractice laws that hold when you're being sued. And I think, as Stuart was suggesting, there are steps you can take within the court system that can make the actual process of lawsuits more efficient, more based on evidence and the like. And I think those are worth pursuing. Virtually every cardiologist I've talked to has indicated to me that he or she engages in extra tests for defensive purposes. When I talk to orthopedists and patients ask for that additional scan, MRI or whatever, the answer that's given, yes, is more often given as a defensive medicine approach than anything else, because a doctor doesn't want to be sued later for having failed to do something even though he or she doesn't think it's really necessary. So I think there are a lot of costs there. But when I've talked to doctors about this, it isn't so much that they fear personal financial loss from lawsuits, because they all have insurance. What they actually fear more than that is the disgrace of being sued. They take it extremely personally when they are sued in a malpractice case, in a way that those of us who are not physicians really don't understand. Most of us in other fields say, you get sued, you just go on. We're used to that. Doctors devote their lives to alleviating human suffering. And the idea that a patient whom they have bestowed trust and mutual direction with sues them is a very hurtful thing, and they just don't want that to happen.